wszystkich bardzo serdecznie na naszym spotkaniu polskich lekarzy w ognisku polskim. To jest nasze tradycyjne miejsce. Spotykamy się tutaj zwykle co 3 miesiące i do tej pory mieliśmy wiele ciekawych wykładów. Zwykle wykładowcami są nasi polscy koledzy, którzy pracują tutaj w Wielkiej Brytanii. Chciałam powiedzieć, że nasza organizacja ostatnio dość czynnie działała i chciałam zwrócić Państwa uwagę na 2 ostatnie wydarzenia, które były dużym sukcesem. Wiele z osób brało udział w tych wydarzeniach, a dla osób, które nie były obecne, chciałam powiedzieć, że mieliśmy bardzo ciekawe spotkanie w konsulacie polskim w kwietniu tego roku. Była to pierwsza edycja Red Diamond, kiedy mieliśmy panel bardzo ciekawych wykładowców. Było 6 osób w sumie i była bardzo interesująca dyskusja. Specjaliści z różnych dziedzin medycyny, poprzez endokrynologię, chirurgię, kardiologię, zastanawiam się kto jeszcze, ginekologię. Było dużo ciekawych prezentacji i można to sobie zobaczyć na naszej stronie internetowej. Nagrodami za udział w tym wydarzeniu były nagrody Red Diamond, które są symbolicznym taką odznaką, którą wręczamy naszym wybitnym lekarzom. Także to była pierwsza edycja i planujemy następne spotkanie w tym rodzaju w przyszłym roku. Mieliśmy również bal lekarzy polskich. Jest to już roczna nasza impreza i były już 2 bale. Oba były w Roehampton Club, cieszyły się dużym powodzeniem. Zapraszamy na następny bal. Już mogę nawet powiedzieć, że data jest ustalona. Następny bal będzie w przyszłym roku 1 czerwca, więc proszę sobie pozapisywać w swoich kalendarzykach. Mamy już zaklepane venue i będziemy oczywiście przesyłać zaproszenia w późniejszym czasie. Jeżeli chodzi o logistykę, chciałam tylko wspomnieć, że dzisiejsze nasze spotkanie, jeżeli ktoś potrzebuje certyfikat of attendance, to można sobie zeskanować ten barcode i otrzymać certyfikat z naszego spotkania dzisiejszego. Toaleta jest tutaj naprzeciwko, także gdyby ktoś potrzebował toalety, to bardzo bliziutko. Mamy dzisiaj 2 wspaniałych wykładowców. Mamy doktora Filipa Zemraka i profesor Julię Verne. Pierwszym wykładowcą będzie dr Filip Zemrak. Filip jest konsultantem kardiologii, będę mówiła już po angielsku, jeżeli mogę. Filip is a consultant cardiologist at Barts Health NHS Trust in London. He specializes in heart failure and adult congenital heart disease. He set up a clinic at Barts, which he runs himself. He holds PhD from the University of London and master degree in health economics from London School of Economics. He is also a Darzi Fellow, which is quite an interesting fact. And today's lecture is about health economics. So thank you very much, Filip.
So, welcome everyone. Thank you for inviting me to speak. First disclosure, I'm on call for congenital heart diseases, so if there's any I will try to speak up. This is more for Zoom. Though it sounds like there is a bit of sound. So my first disclosure, I'm on call, so if I get a phone call, I never get them. I will need to leave for 3-4 minutes. Dorota asked me to speak about health economics, and I thought this is something very different to whatever people do. As Dorota introduced me, I'm a cardiology consultant, but I've been interested in health economics, data, and social services for quite a while. That's why I pursued career, or at least education at the moment, in economics at LSE. It will be a crash course, and I'll try to make economics fun. I will have a few questions, and I will show you that this is the health economics, or economics direct our life as individuals, as systems, as nations, and globally. And I have a slide about my alma mater, LSE. They're starting another uptake for health economics course. So what's economics? I'll read the definition. It's a social science that focuses and describes production, distribution, consumption of goods and services, analyzes the choices of individuals, systems, governments, and global allocation of resources. Almost everything that I've learned at school can be described by the formula or graph. Those are the curves of supply demand, and there wouldn't be an economic lecture without understanding those curves. So think about demand curve. There's a laser point. There should be. Might. Okay. No worries, no worries. So imagine we have pasta. What's the price of pasta? 500 grams of pasta costs about £1, yes. And at this price, we consumers are buying one quantity. A few years ago, just before COVID, the price of pasta was half of it and people were buying more, but I assume maybe in 2 years' time, price of pasta will double, and that will limit the consumption of pasta, at least, well, how much we buy. Where's healthcare on this graph? Hello. So how and when we say if you look at the price when the demand changes with the price, we call good or service price elastic. It's healthcare price elastic. Let's think about it. Does healthcare behave, or healthcare services and goods behave like pasta? If we increase the price, do we consume less? Does it behave as perfectly elastic good? Those are luxuries, and you can imagine very expensive cars or gold. No matter the price, there will be constant demand for such services. Or is it something different? Is healthcare perfectly inelastic? So Dorothy, I'll ask you. For example, today we have the price, or we offer bypass surgery for 10%. Are you going to get the bypass surgery? No, we won't be going to. So if the prices come down to 1% for bypass surgeries, we will not go and choose to have bypass surgeries. Is it the same with medications? Imagine not over here, because the price of any medicine is about £10, so people can afford it. But if someone's on 10 medications, they might want to choose which ones they're using. But for example, in States, if you increase the prices of drugs, people will not use them. So where's healthcare? It's close to perfectly inelastic, but not necessarily. And we know that price in healthcare matters. Those are very old studies showing that this is so-called RAND study. It was run in the 80s in States. It's probably the biggest study in health economics, and it showed that people who had insurance and had some deductibles, so they had to pay a price or a fee for attending outpatient services or acute services. And we know that people who had to pay 90% of price still were using services, but not as much if they were free. And a very different, also very meaningful experiment called Organ Medicaid experiment, in which we noticed that people who won lotteries, which means they had unlimited resources, were using more money for services. So they increased the number of physician visits. This is not only about demand. Healthcare is not only about the demand, it's also about the supply. There is a limited allocation of resources, and we need to think about it, because everything beyond what we can supply means there are unmet needs, and there always will be unmet needs in healthcare. And this is what we need to focus on, or well, we focus on using health economics, how to minimize the unmet demand. Something really important, we need to mention that we live in a country and we have one of the best healthcare services, using almost total universal healthcare coverage, which means that we don't pay for our healthcare services. There are only a few. Protect the NHS. I think we need to agree this is what we need to do. But healthcare economics is not only about formulas and pasta and demand and supply. There are some other interesting topics, and I'll take you through some of them. This is probably my favorite. How do we measure quality in healthcare? It's a very good example. Newsweek just a few weeks ago published a ranking of hospitals. I work at Barts. We managed to get on the 107th place in the world providing cardiology services. Yeah. But how did they get there? How do we choose? How do we select and rank hospitals? So another question. Now we want to have this bypass surgery. Where do you go? Agnieszka. Would you go to your closest hospital? No. Paweł, your relative just had a bypass surgery. How did you choose the hospital? That's quite interesting. So people usually choose the distance, but if there's a hospital that's not much far more than your hospital, people will look at rankings. They're not so available in the NHS. It's way more well developed in the States, but people do look at what happens in those hospitals. And how can we assess it? Number of procedures. If you're choosing a surgeon, you want to know that they do enough, that what's their 30-day mortality, infections. But those are all very specific, not outcome measures. Well, those are outcomes, but 30 days, if someone dies at day 31, it's less. How can we measure that? And what Newsweek did this year, they changed the way they assess hospitals, and they put a lot of focus on patient's experience. This is something that I think we all should be focusing on. That brings me to a very similar question. How do we know that we do a good job as a doctor? Tomek? But how do you know that? That's great, but probably not all of them. But you're right. We do. I do agree, but so we do feedback. This is informal feedback. There are some formal ways of collecting it. We all have to do it every 5 years, get 20 patients that we pre-select. What about doing it in a more systematic way? Patient-reported outcome measures and patient-reported experience measures are becoming way more relative to healthcare, and we'll be using them more. So in orthopedics, everyone who's having a hip surgery, I think hip and knee in the UK, they get a survey about how they feel. They do the same thing just after the surgery, and then they're followed up with the same survey 6 and 12 months after the surgery. And this data is widely available and very important. And of course, not yet implemented in the Newsweek report, but it's a friends and family test. How do you know? You have to have your operation. If I needed an operation at Barts where I work, I would ask the nurses in theatre who's the best, who would they choose. So friends and family test is really important. If other physician asks you for advice, it's a compliment. But if they bring their child to you, that's It's huge. I'll come back to those patient-reported outcome measures. They're very, very important. How can I assess my practice? So I do heart failure. We are being measured by, in the national audit, I know how many patients I put on ACE inhibitors, how many on beta blockers, but it doesn't tell me if they feel better. What I invested in just at the very beginning, I've been working 3.5 years from day one, I implemented patient-reported outcome measures. This is one of the specific scales for symptoms in heart failure. It's called Minnesota Living with Heart Failure Questionnaire. So anyone who comes to my clinic needs to fill in 30 points, 30 questions survey about how they felt in the last 30 days. So apart from patients coming back to me, I know that they're improving. Also saves me time because the moment they come to the clinic, I know, well, in this domain, they're great, they've improved, maybe they're more psychologically. So over here you have questions about their physical well-being, heart failure, a bit of social, but also psychological. So I know what to focus on. Something else that's very close to everyone in health economics is introduction of new drugs. Again, I don't think I fully understood how that worked before deepening my knowledge over here in economics. So if you want to introduce a drug, let's assume I've invented the drug for heart failure and I think it's great. So I'm representing a pharmaceutical company. What's the first way we can do? We have to do is show it's safe and efficacious. How do I do it? Controlled trials. Yes. So phase 1, I take 5 patients or 5 individuals, give them the drug. I hope they survive. In phase 2, I take maybe a bit more, about 100. Some of them might improve, and then I go to a randomized controlled trial. And this is what happened with one of the recent drugs for heart failure. It's called Entresto. It's sacubitril for Satan. They compared it instead of with placebo with the old drug for heart failure called enalapril. And the study, the randomized controlled trial, showed that people who were using it were dying less, were not being admitted to the hospital. The manufacturer, pharmaceutical company, submitted the data to European Society of Cardiology. They implemented it into guidelines. But does it necessarily mean that we should implement this drug? How much does it cost us? So we do have services, we do have institutions that do it. In the UK, it's the National Institute of Health and Care Excellence, NICE. They assessed the provided data from the pharmaceutical company, and they showed, which showed that to improve quality of life, or measured by QALY, it costs less than £18,000. Was it enough to implement this drug on the UK market? Yes, of course. The threshold by which NICE in the UK accepts drugs is between £20,000 and £30,000. And how do you do it? By assessing ICER. If you have a look in this slide over here, you can see the cost difference. So this is increasing cost, this is increasing utility. And by increasing utility, I say this improves life. So QALY is a quality adjusted life year. If someone lives twice as long, the quality will quality improve. But there's also something about quality. I'll explain it in a second. So have a look. If we assume that one QALY is here and it costs £30,000, this is how much NICE in the UK accepts. So everything that has this incremental cost effectiveness ratio over here will be accepted. Everything that's too expensive won't be. There will be drugs compared to Entresto or similar to Entresto that will be cheaper but maybe less effective, but at the same time they will be approved. It's up to us to decide which one, how we're treating patients. and how we utilize resources. How do we measure QALYs? Does anyone know? That's very interesting. So pharmaceutical, it's a very new concept, but pharmaceutical companies, apart from assessing the efficacy of the drug, so saying, does it improve mortality? Does it improve hospital admissions, etc.? It also gives all the individuals who take part in the trial, give them patient-reported outcome measure scales. So those, this is the one approved by NICE or used by NICE. That's internationally recognized. It's called EQ5D5L. Individual gets it at the very beginning of the trial and of the trial, and that allows us, in combination with the outcomes, with clinical outcomes, to measure QALYs. But this is only about the drugs. Remember, I showed you we have limited resources. We also need to think about how we utilize the resources that we have right now. This is one of my studies that I wanted to show you. So 1% of population will have bicuspid aortic valve. Aortic valve usually has 3 cusps. 1% of us will have 2 of them fused. 30%, so maybe 1 in 3, 1 in 4 individuals who have bicuspid valve at some point will need aortic valve surgery. Not a lot, but that's quite a proportion. And then when we take the family, first degree relatives of the person who has bicuspid aortic valve, we will find 1%. So out of 10, we'll find 1 who has bicuspid aortic valve, and out of those relatives, someone will, or maybe 1 in 3 of them, or 1 in 4 will at some point require surgery. So imagine, Agnieszka, now question to you. You're being found, you have an echo for something, and we find that you have bicuspid aortic valve. It's working fine. You probably will never need surgery, but we'll just screen your relatives. Good. Tomek, would you send your patients, relatives of the patients with bicuspid aortic valve for echo screening? Exactly. Is it required? Individually, I think yes. If I have it, I would like to know if my children, my brothers, sisters, my mum, dad to have it. And it's recommended in guidelines. American guidelines say, yes, if someone has bicuspid aortic valve plus 1 extra risk factor, which is dilated aorta, we should be screening their first-degree relatives. And European guidelines say, yes, it's appropriate, so it should be done. But how much does it cost? And this is, don't have to do economic evaluation. You don't need millions of pounds. You can do it on a piece of paper and access to the internet. So I thought, well, how much are we paying for it in the NHS? Because in my clinic, I get a lot of patients to get screened, but who's paying for it? So I looked at number of births over here. Took a year, 2005, because the individuals are now 18 years old. So there were 750,000 births, 1%, so slightly under 8,000 patients had bicuspid aortic valve. Calculated how many siblings they have. It's all available from the Office of National Statistics. I put some numbers, I got some numbers, how much it costs to get an echo, a review every 5 years, how much it costs to have a surgery, put it through, again, another formula. I calculated how much it would cost to perform screening and do not screen individuals. And I found that we would probably identify through screening 142 individuals that would not develop symptoms, and we would possibly prevent their death. This is very theoretical. So we're screening those patients. If someone has a significantly narrowed valve, they will have symptoms. We're assuming that 142 we would save, but it's probably less. So we're spending quite a lot of money to save 142 patients. How much does it cost? 10.5 million per 1 year screening. And just imagine that accrues every year. We cannot calculate QALYs because we have not done patient-reported outcome measures, but we can use other scales. DALY is very similar to QALY. It's a disability-adjusted life years lost. The cost per QALY or DALY is almost $1 million. The willingness to pay in countries who are well developed is very similar to ISA. So for an intervention, we would be willing to pay about 20,000, 30,000 pounds, but we're spending 800,000 pounds. Just imagine how many nurses we can employ, how many hip surgeries we can perform, etc., etc. Not published as yet, but presented at ESC and British Association of Congenital Cardiology. Aortopathy, screening first-degree relatives of patients with BAF does not meet cost-effectiveness thresholds. I think, and I'm hoping it will get to the BMJ, but we'll see. A small, maybe I'll finish in 2 more minutes. Which option would you choose? I absolutely don't like behavioral economics, but I think this is important to think, and I'll show you why, about psychological processes at the global scale. We have a few people over here. Which options would you choose? Go to the casino and they tell you you get £3,000 with 100% probability, or you have 80% of chance of winning £4,000, but you have 20% chance of leaving the casino without any money. Who, with no loss, who will choose option 1? Ah. Well, what about that? So, you go to a casino and you're 100% certain you'll have fun, but you will lose £3,000. But option B means that you go there, you can gamble, have fun, but there's 80% of chance that you will lose £4,000, but there's a chance that you will not lose anything. Which one do you choose? Option A. And option B? Of course, someone mentioned that. It's loss aversion. And a slightly different way of looking at loss aversion is fear. Yes, we are wired to avoid loss, and that's a description of fear. This is what brought me to this slide. Cardiovascular disease is the biggest killer in the world. Wherever you go, and the number of deaths from cardiovascular diseases has been increasing, and there's no stop to it. But if I look how much we invest in drugs in cardiovascular diseases, this is that. I think, yes, this is yellow. There was almost no investment. I think there was Entresto there. And it, yes, of course, oncology, and that. This is exactly why. Central. I think it's probably more because, well, it's the investment in research, yes. And why? Why are people investing over here?
They're seeing the fruits of the success of oncology. Look at immunotherapy. It's made dramatic changes in certain cancers like melanoma. 5-year, 7-year survival now is over 50%, whereas it was less than 10%.
Perfect, but how many?
I don't see that same big difference in cardiology.
How many people die of melanoma? Not too many. I know. I'm not saying it's bad. It's cardiovascular disease, and this is exactly where it is. And I found this survey that was done a few years ago in Norway. They interviewed slightly over 400 individuals of the age of 50 to see which diseases they fear. Alzheimer's disease, 40%. You can see. neurological diseases here. I think HIV, there's a little bit of increase. Yes, people are investing in antibiotics and antimicrobials, antiviral diseases. What else? So Alzheimer's, 39%, cancer, 30%. Who's afraid of cardiovascular disease? No one. No one.
But even in palliative care, people think that they're very long living, you know, if they've got oxygen at home and they can barely get across the room. You don't think about death in the same way as cancer patients.
That's
I'm trying to get them to put in advanced care plans or something. They just have got used to it, even with very campaign.
exactly. I still haven't found answers. How to convince individuals in the clinic and how to convince governments, the public, that we should be investing in that and focusing on cardiovascular diseases. We're looking for answers. You can get tools when you go a little bit deeper into health economics. Great, thanks so much.
Thank you. Thank you very much, Filip. Are there any questions in the audience?
So the major condition strategy being produced by the DH with many stakeholders has cardiovascular in it. And we're focusing on primary and secondary prevention.
Which is great, and there will always be focus, but you cannot get the society to agree with that. There will not be as much focus as on things that people fear of. So cancer, Alzheimer.
I think things have also changed. When I was a junior doctor in cardiology at Northwick Park, I mean, very junior, and I remember patients lying in the CCU that were 55 years old, 60 years old, sometimes family members, and you don't see that now so much. They're very, very young people having heart attacks, and maybe people have forgotten already. And so, I don't know, you're the expert, but I think that when I look at the big statistics, it's more about chronic cardiac failure, which is your specialty, but they have forgotten young people dying of acute MI.
So thank God most of people don't die. We do our best, and we have advanced. We can treat people, and
Yes, but also the treatment of MI is just amazing. You know, you have a chest pain, you end up in hospital, you're having treatment.
Exactly. 2 days later, after a heart attack, you go home
with almost no damage to your myocardium, which wasn't really possible.
That goes back to my earlier point. I think you get more bang for your buck in cancer research than you do in cardiovascular. That's my argument.
Exactly. Maybe we're now victims of our own success.
When you're waiting for the big paradigm shift, what's going to take you to that next level? Whereas in cancer, we've had this big wave, we've sort of coming to an end of it now in therapy and optimize that. But what's the next big thing?
Hopefully nothing. Hopefully we'll level it down.
Thank you very much. Any more questions? Okay, so we're going to move on to our next.
I've got a question. Hello. I've been putting my hand up.
Yes, ask the question, please.
You're talking about highly interventional.
Okay, hold on. I'll give
You're talking about highly interventional stuff. You're talking
okay,
about.
now we can talk, Evan.
Yeah,
so
can you hear me? Yeah, you're talking about you're talking about highly interventional medicine, which is expensive. Let's face it. Why don't we talk about public health? Because at the end of the day, I'm seeing an increasing number of teenagers and children with type 2 diabetes, which I didn't see before. Can I?
Sure.
I'll the question.
No, of course. I'll comment on it. So I don't know. I haven't heard your name, but this is exactly.
Look, but I haven't quite finished. So if you look about the number of obesity, the type 2 diabetes, the vaping, the cigarettes, the mold in houses, the cold in houses, we're looking at an increasing number of deaths, and then potentially an epidemic of obesity and obesity-related disease. that's going to have a major impact. Can you please comment on that?
Yes, and what's your name? Eva.
Eva.
Oh, yes. So Eva.
Eva Lichtarowicz-Kryńska.
Eva just said, which on purpose I did not put obesity over here, and I only showed highly interventional stuff and investment in drugs. But this is maybe a signal that we're also not investing in primary prevention in the childhood obesity. But the relationship is similar. We don't need investment in highly specialized drugs. Populations, societies are not afraid of cardiovascular disease. That's why we cannot somehow enforce or shift the focus from highly specialized drugs for Alzheimer's that will save someone's 5 years IQ at the end of their life for lifelong of treating or consequences of diabetes. But this is exactly the same phenomenon. People are not afraid of cardiovascular disease in any form and shape.
But it's not just obesity.
Thank you very much, Filip.
Filip, it's not just that. It is also the cold, the lack of heating, the mold, the teenage vaping, and you're talking
So I'm going to
about a life
introduce our
respiratory
next speaker, if you
disease.
don't mind. Is that all right? We have a bit of a problem with connection with our Zoom
Yeah, so you're not
participants.
hearing our questions, and we can't really see.
So we have our next speaker. We're very privileged actually to have here Professor Julia Verne, who is a consultant in public health medicine. In addition to her medical degree, Julia has a PhD in epidemiology from the University of London. She has PhD in bioethics from the University of Krakow. She also has doctors honoris causa in business and law from the University of West of England in Bristol. Julia is currently the lead for clinical epidemiology in the Office for Health Improvement and Disparities at the Department of Health and Social Care. Her major interests are in palliative care and liver disease. Julia leads the team producing the National Atlases of Variation in Health and National Mental Health and Dementia Intelligence Network. It's actually quite fascinating. And Julia is actively engaged in research and has over 100 scientific publications. So she's going to talk today about
I'm going to talk a little bit about my work.
Yeah,
if
your work,
that's
absolutely.
okay.
Thank you very much.
Thank you. Well, thank you. It's a great honour to be presenting to all of you and colleagues online. My uncle, how do you say, uncle Pravojek, was a member of this society. Yeah, and Pani Bożena knew my father very well. We lived on the same road. It's altogether a great privilege for me to be here today. So I'm going to talk to you a little bit about my work. And Filip, thank you for setting it up, because I'm not going to talk about health economics, but it is absolutely critical to everything that I'm going to talk about. So, which is the magic button to go forward? This one. Oh, that one. There we are. So I'm a public health consultant, but my major area of research is clinical epidemiology. So I try and keep my clinician medical hat on, but I analyse with my team very big databases, national databases, so mortality, HES data, hospital admission statistics, GP data, and so on. And one of our products are the atlases of variation. We base our analysis, almost all the analysis my team is doing, on this concept, first proposed by Professor John Wenberg from the Dartmouth Institute in the States, that everyday clinical practice, whichever evidence-based intervention you think about in your specialties, there are wide variations geographically, which aren't explained by the severity of the illness or patient preference. So if you compare, some people are getting aortic valve intervention close to Philip's Centre, but if you live in Hull, you won't get it at all, perhaps. So I put a public health perspective on it. So I say everyday health intervention, so that might be smoking prevention and other things, right the way through to end-of-life care, are also characterized by very wide variations. And largely I'm talking about geographical variations within a country, but they could be across country to country. And they can't be explained by socio-demographic factors, illness severity, or patient preference. And they're due to these things: limited budgets, making bad decisions about investment or not disinvesting and investing, lack of understanding about what the evidence base says about interventions, and really not making bold decisions, and especially not tackling the gross inequalities we see either by deprivation or ethnicity or other things in the population. Sorry. So this is the Atlas program. It was started in this country following the model from Professor John Wenberg at the Dartmouth Institute in the States by Professor Muir Gray in Oxford. And my team took it over here in 2015 when we were in Public Health England. And subsequently, we've continued to produce atlases of variation. So for example, in palliative care, in respiratory disease, last year we produced one for the first ever time on vision health. Which was very innovative because mostly we focus on things that kill people, but it's a big thing about quality of life for older people, but also impact on the NHS. And currently our latest atlases that we're working on are on lung cancer and on head and neck cancer. All of those atlases of variation, which I'll show you a little bit more about what they contain, are produced in partnership with clinicians and with charities and with national organisations. So if there's a national clinical director, they will be on our steering group. If there's a national audit, for example, in lung cancer, the lead for that national audit will be on our steering group. British Thoracic Society, charities for people with lung cancer, or similarly for liver or palliative and end-of-life care. So I'm going to show you the way we present data. So these are examples of maps, and this is looking at outpatients, vision outpatients, which is one of the biggest consumers of outpatient services in the NHS. The maps on the left-hand side show the CCGs, now called sub-ICB populations, divided into fifths. So there are about 104, so there'll be about 25 in each group, showing the degree of variation. So the darkest colours have the highest number of outpatients appointments, but it's standardised per age standardised per 100,000 population. On this side, on the right-hand side, we're showing the statistical significance, the difference from the England value. So you can see some areas. I used to work in the southwest, down in Cornwall. They've got stacks of outpatients appointments for vision health. And then we show within that trend chart. So on the right hand side, you've got these things called box and whisker plots. So the little line, come around here, the little line in the middle is showing the England value. The box is showing between 25th and 75th centile. So half of the distribution is in there. And the little whiskers at the end are showing the far outliers. And what we're showing is trend over time. So there's been a significant increase, but not much change in the distribution. So some areas have got masses of outpatient appointments for vision health for their age standard population, and others not very many. So imagine the poor people who live in those areas. During COVID, we were very active, and we showed that for example, cataract surgery absolutely plunged. You could see it crash in the first year of COVID in April to nothing, and then start to recover. And this was early in 2021, this 2020, but we've shown that gradually cataract operations are returning to the level that they probably ought to be, although significant geographical variation in England. Once we've produced an atlas, we then put this material on what's called our fingertips platform, which is available to all of you, and you can interrogate it if we've done something in your particular area or something you're interested in. And here, local decision makers, say in CCGs, can home in on their area. So Gloucestershire is highlighted here, and they can see how they are performing relative to the rest of the country and perhaps make decisions about investment or disinvestment. In the atlases, we have various sections for each indicator, and that will give the context. It will describe how big the variation is, but also direct, particularly local commissioners, to think about what they ought to be doing. And we link it with the evidence base for that particular indicator. So we don't, in general, generate indicators on just anything. It has to have an evidence base, and usually that is produced by NICE or one of the national organisations. We have a website, well, not a website, a landing page on gov.uk, which links to all of our atlases of variation, but also the other indicators. And when we put something out, I'm now very restricted working in the Department of Health to do a lot of publicity, but we did manage to get a tweet out about updating our vision atlases. We're not just all boring sitting in the back room and doing big data analysis. During COVID, particularly because I specialised in palliative and end-of-life care and was one of the few people who knew anything about care homes, we were sort of pushed to the, not like all of you, front line in the hospital or in general practice of seeing patients, but front line of monitoring and trying to respond to the COVID pandemic. So my team were daily monitoring the appalling death total in care homes. Absolute horror. It was every day monitoring. And particularly it was a horror at this point because the modelers from Manchester were modelling how high this peak was going to go. And we were monitoring it, and every day we were almost hitting the modelling. Here we were monitoring outbreaks in care homes, and the red shows where there were more than 10 patients involved. On the far side, we were comparing the trajectory of the pandemic in different regions, and you can see that, for example, in London, massive peaks in deaths at the beginning and a smaller peak here. But for example, in the southeast, particularly when we saw the new variant spreading, we saw many, many more deaths. And then finally, it was coming just too late for the second wave, the uptake of vaccination. But I'd just like to draw your attention, sorry I keep walking across the screen, to this, because I've showed you box plots and degree of variation. It's very rare that we see this amount of success. So here, vaccination was being brought in, wide box plots, massive spread in the whiskers. And gradually, as vaccination was rolled out, everything bunched up to the target level, which was over 95% of residents of care homes being vaccinated. So if only I could see this transformation happening with time for other procedures which are evidence-based, but usually it takes decades for those to change. So we also did our maps showing change in care home deaths by local health administration. And on average, there was 21% increase in deaths in care homes, but quite a lot of geographical variation across the country. In some areas, the southwest, they managed to protect people much better, but then there also wasn't quite so much COVID about. So moving to one of my other teams, which works on dementia and also neurology, but I'm just going to talk about dementia. We showed that, so GPs, there's a QOF target for GPs to put on their dementia registered patients, but they have to be diagnosed. They have to go to a memory clinic or something similar. GPs will correct me, to get on the register. And the target is about 2/3, 66%. So the GP should have captured 66% of their people with dementia on their registers. And it's predicted how many they will have. But we showed a big drop in the number of people registered with dementia during the beginning of COVID, and indeed for the first 18 months. And we analysed to see whether that varied according to the area of deprivation, and it did. If the GP practices were in the most deprived fifth of the population, there was a much bigger reduction in the number of people on their GP registers. If they lived in urban areas rather than rural, there was a significant reduction, and there was a much more significant reduction in the north of England compared to the south. We've had a look at the recovery of this, and although it's bouncing back, it hasn't nearly reached the level that is predicted. And so there is a lot more work to do to catch up, to identify people with potential dementia, send them to memory clinics and get them on the GP register so that they can also get treatment. But we have tools for local areas and GP practices to analyse how they are doing compared to anyone else. And they could say, well, you know, I'm in a more deprived area. We can say, yeah, but some of your colleagues are in a deprived area, equally deprived, and they're hitting their target with using this interactive tool. So now a little bit about our work on end-of-life care. So seems ages ago, but in 2018, we produced another Atlas of Variation. It was the first actually in the world to do a country Atlas of Variation in palliative and end-of-life care. But we keep it updated. So on the Fingertips platform, we have lots of indicators of need for and sort of proxy indicators of quality. And so my colleagues and I sometimes too, we run both webinars and go out to regional groupings of palliative care specialists plus the commissioners and talk about how to use our data. In the Health and Social Care Act, ICB, so in the Integrated Care Boards, were given the responsibility, so it's mandated in law, that they need to assess their populations for need for palliative and end-of-life care and implement palliative and end-of-life care. So we've got a whole range of indicators. Some of them are our profiles, but we link with others on the Fingertips platform to talk about, for example, the nature of the population. The more older people you have in the population, the more you'll have to provide palliative care. The more deprived population, the more challenging it might be. So this is an example of what local areas can see, and they can see how they are performing compared to England or neighbouring local administrations. This is about the potential population need, but I just want to show you some examples. So this is from the northeast of England, and here we're looking at the percentage of people aged 65 or over who are living alone. So most people would prefer to die at home if they possibly can, or at least be cared for at home. But if you're living alone, it's much more challenging and you need more support. And you can see the deep red areas have the highest proportion of people living alone. We have other indicators like percentage of households living in fuel poverty, and that has been updated. I'm just showing you 2020. But poor old Hull in the northeast of England has one of the highest proportions of over 65s living alone, the highest in the region fuel poverty in the household, and actually the lowest number of GPs per head of population. So providing community palliative care in Hull is an absolute challenge. Plus, lots of inherited smoking related problems, COPD, lung cancer, heart disease. It's very, very challenging. And what about social care? Philip, I thought you were going to tell us something about social care. We also show how challenging that is, because actually when you're caring for people at the end of life, you need social and medical care, and you need social care workers to either go out to homes or to staff the care homes. And we are facing an absolute crisis in staff in social care. So moving on to lung cancer. So this is our forthcoming atlas, but we're going to split it into an edition that talks about incidence, mortality, and so on. And then we're going to do an end-of-life care section, and then we're going to do the middle, which is more challenging, which is about the oncology section. So this map shows the proportion of patients who died within 6 months of their first diagnosis and how that varies geographically. So the left-hand side is just straight variation. The right-hand side is significance from the England value. But it is shocking that in the lowest areas, under 40% will have died within 6 months, and in the highest areas, it's half of all patients. Question, why is that? Are they presenting later? Is it because they've got comorbidity, and or is it quality of services? And my trouble is sometimes trying to disaggregate those things. But we can see that stage at diagnosis, late stage at diagnosis, is incredibly important. Going back to my interest in palliative and end-of-life care, we have a national proxy indicator for quality, which is place of death, because, as I said earlier, many people would prefer to be cared for and die at home. So you can see in the dark line here, there's a deaths in hospital proportion of people who died in hospital, and this blue line is at home. And gradually, over the period of national policy, and I set up our intelligence network in 2010, but over a period of national policy, there's been a reduction in people dying of lung cancer in hospital and an increase at home. In COVID, boom, the lines crossed. So sometimes unexpected things happen that completely change practice. Now, we don't know how much was individual choice, how much was people recommending it's better for you not to come in hospital, and we don't know about quality of care. But that sudden jump to more people dying at home has persisted out in time. Sorry, I haven't got the graph for it, but it's drifted down a little bit, but basically that stepwise change that occurred in COVID has persisted. Another proxy quality target is 3 or more emergency admissions in the last 90 days of life. So that's the last 3 months of life. And you can see massive variation. Along the bottom, we've got regions. So this is the London region, but London has got its act together in terms of pan-London policy on palliative and end-of-life care, more hospices per head of population, more community palliative care teams, and perhaps better identification and working with oncologists across Greater London. So here, fewer patients with lung cancer have 3 or more emergency admissions, and there's not a lot of variation. But if you look at Northeast and Yorkshire, the region I was just showing you, massive variation. So in some patches, patients will be bouncing in and out of hospital in their last 3 months of life, which is very distressing for them and their family. And recently, we've just submitted a paper. You need to delve behind that, look at deprivation, because that influences, and ethnicity. And in a recent paper we've just submitted, ethnicity is quite an important factor in emergency presentation in the last period of life for cancer. And we don't know why. Is it because people don't know how to access services, or we don't reach them with palliative care services? Or is it something cultural? For example, one of my colleagues who came from Nigeria said, well, I don't know why you're working on this, emergency admission at the end of life, because in our culture, if we didn't take our loved one to hospital right at the end, it would be a disgrace in the community. So we need to really understand what those differences are. And here we're showing whether the patients were seen in their last admission in hospital. They may or may not have died in that admission, and whether they were seen by palliative care. And again, in London, it's much, much higher than elsewhere. I just would like to, if I can, talk about quickly about 2 groups of conditions where there is either stigma and or blinkers. And those 2 populations are people with severe mental illness and people with liver disease. I mean, largely lifestyle-related liver disease. But I am completely and utterly failing in making a difference. And why is that? I don't have the answers. So in April, we produced a report on premature mortality, so early death in people with severe mental illness, and largely we're talking about schizophrenia, psychosis, and so on. And it was an update on previous reports that we've produced. And people with severe mental illness die on average 20 years younger than people who don't have severe mental illness. 2/3 of them die of physical conditions, so those are all the big ones: cancer, heart disease, often smoking and lifestyle related. and think issues like obesity and smoking are much higher prevalence. But the awful thing is that we analysed it with 3-year blocks. So over the last 12 years, the premature deaths in people with severe mental illness have gone up. We made no impact. And the poor National Clinical Director for Mental Health, who is a psychiatrist who works with the homeless, is heartbroken. You know, it's his life's work. And why are we as society completely failing to do something for this group? And you can see big jump, particularly in males here and females here, but for each group, particularly in males, it's really increased. And that last period does include the first year of COVID. And we're just about to publish a report on what COVID did. But here we show that the chances of premature mortality in this group increase with deprivation. So the higher the deprivation, or the area of deprivation in which those individuals live, the worse their chances are, or the higher the chances that they'll die early. And here again, I'm showing it in a different format. This is the most deprived fifth of the population and the most affluent. It's absolutely enormous, that difference. Look, it's not a gradual trend. People in the most deprived fifth of the population, it's a stepwise drop even to the fourth most deprived. Absolutely shocking. And we published a paper showing difference in uptake of screening, cancer screening. And if you've got SMI, it's worse than the normal population. If you've got SMI, severe mental illness, and you come from a deprived area or an ethnic group, it's worse and worse and worse. So all these factors also multiply to really marginalize people with SMI and make it difficult for them to access health services. So maybe we need to go to them and think of new ways to organize health services. And now just a little bit on liver disease. We work very closely with the British Liver Trust. Liver disease is the second biggest killer of working age people after accidents and death by suicide. So it kills people really young. And this is, I don't think you're going to believe this when you look at it. People who die of alcohol-related liver disease die 30 years younger than the normal population. 30 years younger. And you can compare other things. So, you know, under the age of 55, 46% of females who died from liver disease will be dead before 55 years. And again, there's a very sharp socioeconomic gradient, almost five-fold gradient. This is actually by deciles instead of quintiles, but it's the same for other causes. That's alcohol-related, and then you've got the other causes of liver disease. And then if we look at, so what are our chances of finding people with liver disease? So anyway, the answer is we need to be much more proactive in primary care, because by the time people with liver disease land in hospital, they are very sick. And some of them die in their first and only admission. So over here you can see admissions during the last year of life. I use this both for prevention and for delivering palliative care, because I say, well, these people at the end who have real masses and masses of admissions to hospital, we could find them, see if they are suitable for transplantation. If they're not suitable for transplantation, we need to think about probably end-of-life care planning. And if they've got resistant ascites, then their life expectancy is about 6 months. But at this end, it's all about prevention, because these patients come into hospital. 50% of patients with alcohol-related liver disease have 1 or 2 admissions in their last year of life, and they die in one of those. They just come in very sick, crashingly ill. Sometimes they're not recognised as they come through A&E. Sometimes there are problems getting them to ITU, and that's the stigma or blinkers, because often ITU doctors think, why should I give my bed, precious bed, to a patient with alcohol-related liver disease? But some of these are salvageable, and sometimes it's a road to Damascus moment as well for the patients who go to ITU. They think, My life was saved. This was so awful. And they managed, with support, to stop drinking. And we used that data in that last graph to beg NCPOD to, they couldn't repeat their full audit of patients who died in hospital with alcohol-related liver disease, which they'd initially done in 2013. It is a horrific, if you read that NCPOD report from 2013, it's horrific. Missed opportunities to save lives. So we persuaded them to update it using the data, and they showed that things have improved a bit, but not nearly as much as one would hope. And the graph on the right-hand side shows whether they had any contact with palliative care. So we published at the end of last year, the very beginning of this year, 2 articles, one based on the data on alcohol and the NCPOD report. This is in the Lancet, and that was Lancet Gastroenterology, and one talking about palliative care for these patients. And just finally, on a cheery note, I think this was the highlight of my year. It was a very weird thing. Every year I go to the European Association of Palliative Care. And this year I felt very honoured because out of the blue, and probably based on abstracts I submitted based on my PhD in Krakow some years ago, they said, can you run a workshop on We Are Also Going to Die? Oh, wow, it was an hour-and-a-half workshop. And it was really interesting because there were about 60 people. They're all specialists in palliative care. And it was more, not my big data, this was about philosophy and have we thought about dying and what are we afraid of? But it was interesting because what are we afraid of? They weren't in general that afraid of physical suffering at the end because they thought that their colleagues would probably sort them out. They were really afraid of, is there anything beyond? You know, the existentialist spiritual concept, you know, and there were only 3 out of the 60 who said they weren't afraid of dying. And they had all had near-death experience, you know, very, very serious illnesses and come close to death. And then they reapproached life with new vigor and said, every day is precious and counts. And, you know, I've been close to death, now I'm going to live. They weren't afraid, but all these specialists in palliative care still had, you know, concerns. So it was interesting. So thank you very much. I hope that was a bit of a whistle-stop tour.
Thank you very much, Julia. I have to say, you mentioned mental health crisis and so many young people dying of mental health issues. We had a very interesting lecture by one of our colleagues, Dr. Andrew Mołodyński, if I remember, psychiatrist from Oxford.
Yes.
It's actually on our website. You can listen to that. And he was absolutely horrified how many young people die of mental health illness and the provisions for care for those people. As a GP, I can tell you, and my colleagues GPs probably will confirm, access to medical service, to mental health services is so difficult, and you virtually have to be, suicidal or dying before a psychiatrist actually will take interest in you. Otherwise, they are just dismissed to GP, no psychological support, and psychiatrists will see them once and discharge. Very, very challenging for GPs, and to be honest, I'm not surprised. I don't know if colleagues have the same experience.
I was just going to say, related to that, I don't think you mentioned that or showed the statistics for Scotland, but there's been a lot of coverage about the drugs problem, and Scotland, I think, has the highest in Europe.
Yes.
I wonder what your thoughts are on what's driving that.
In Scotland, it's the trade. Yeah, illegal importation of drugs. And certain desperation in society, because I think with the economic crisis, perhaps problems in worklessness, we need a whole society approach to tackle some of these problems. They need to get tougher somehow or other, and it's very difficult on drug importation, illegal drug importation and distribution. But secondly, we need to give people a reason to live and something to, and that means being able to earn a living and have a place to live and have your family and so on.
My question, the atlases you produce are fascinating. Are they actually, the data from the atlases, is it then, does it influence political decisions about allocation of funds or services to certain areas? What was the outcome when you produce an atlas and data for a particular region and particular clinical issue?
So, for example, in palliative and end-of-life care, since 2007, I've been on the national steering groups for palliative and end-of-life care. And together with policymakers at the DH, but NHS England in particular, we have identified those proxy indicators, for example, place of death or 3 or more emergency admissions. And they use our data all the time to influence policy. In liver disease, well, you can see I failed. And the question is, what is going on with mental health and liver disease and those conditions that affect the most marginalized in society? Is it stigma or is it blinkers? Is it there's another term which is sort of selective vision.
Look away, yeah.
But why are we not managing to do anything? So in Scotland, back to Scotland, they have introduced minimum alcohol pricing. We've tried that here, but we haven't managed to succeed. Many of those most vulnerable people, the people with SMI, have dual, triple diagnoses. So they probably also are dependent on drugs and possibly alcohol, either or. And liver disease. And in fact, that's the next thing I want to look at, is how many of my people with alcohol-related liver disease have severe mental illness. And I've been in touch with some consultants at the London hospital who are particularly interested, and they say loads. And actually somebody also from Newcastle said he had a trainee psychiatrist in his clinic, and at the end of the clinic she said, all your patients have mental health problems.
How can we rely on the statistics for mental health where so little is actually diagnosed? I mean, the GPs, I don't know, do you diagnose it, or you rely on the referral to CAMS and then they wait for 6 to 8 months? And
The referrals can be one way of collecting data, but also when you see patients with mental problems that have to be coded, national diagnosis. So they all coded, so they are searchable.
right.
But it is the
Present, obviously, because if they don't present to us, then we don't know. Sometimes first presentation is suicide, but then it's coded, so, Mateusz,
Can I just answer that question quickly, though? Sorry, but it's a very perceptive question, because it's true. These are based on either coding in general practice, or in this case, based on contact with secondary care services. So it is really difficult, actually, to get a precise measure of people with severe mental illness, and that is a slightly broader category than just psychoses and schizophrenia. Sorry.
Before you have a question, very interesting you mentioned at the end about palliative care and the meeting you had. Mateusz has special interest in palliative care, and he actually agreed to give us a lecture. I don't think many people know about hospitium for non-dying people.
I agree with you. There's a question about what. Well, actually, I have this idea that the fact that we just deny the existence of death, it's at the core of many issues we have, and probably why we know cardiovascular disease as a problem that affects us all. But I just wanted to comment a little bit of the serious mental illness patients. I work in Victoria, and I actually am GP responsible for reviewing these patients. So the patients who go on SMI register in GP practices in London, they get one extra GP review a year and one follow-up. But what I've noticed is that I think the problem is very complex, because what happens to patients on the mental health register is a consequence of dwindling resources in the community. They get isolated in the community. They're very often very, very lonely. There are comorbidities that they present with. It happens more with people who are economically deprived. If they're from more affluent background, they get support from their families. It's very difficult to get them engaged, and there is very little support in the community. So if they come to see us for 15 minutes once a year and then 15 minutes for follow-up, That's just not enough. So I think the part of what's happening is just resources are not there for primary care.
So I've got more general question actually. So the data you gather, get and analyze obviously is crucial from the healthcare point of view. You probably identified quite a lot of shortcomings which need to be then corrected, influenced. And how do you do it? I mean, do you report it to the government, NICE, or do you influence directly former CCGs? And then how do you measure the outcomes of it? Presumably you do check if what you are trying to change has been done. I'm just more interested about the general picture, not only about mental health, but healthcare provision in various fields.
Yeah, so with the data, the big data sources are mortality, so that's complete. But sometimes we find weird things when we link it with HES data, hospital inpatient data, that it appears somebody's died twice or something. So the first thing we do is to clean the data and check for oddities. But usually the oddities in those very big data sets are only a few. With the primary care data, because we don't have a national system for primary care data, we only have a selection of the GP practices across the country, which is in CPRD data. But it's fairly representative. And then sometimes we have to statistically, I was going to say make up, it's called interpolate, but we have to calculate what it should have been in the areas where we don't have the data. But we feed back all the time to the agencies that collect data, particularly about the GP data, the need to tighten up diagnostic codes. The diagnostic coding is improving, so we can see it improving, and we report back that it's improving on some conditions. Some things are driven through targets. So, for example, that the dementia register is driven through what's called the QOF, Quality and Outcomes Framework target. So GPs get paid for reporting or registering certain things, and that tends to push up the quality and completeness of recording. In terms of things not happening, like interventions, we present this data to the government and to the leaders of the NHS, and so they know where there are difficulties. But the problem, back to Philip's point, is what do you do with the limited envelope of money, and how can we shift it around to do some of these things which are really important? And yes, sorry.
And then the idea on the data you gather, I mean, where does it come from? Do you get instructions from the government or WHO, or you just know what you should be focusing on?
Yeah, so all people that sort of work in my field, in the government or in the NHS, we tend to use the same sources of data. So they are national data, but they are anonymized. So we can't tell individual patients. But for example, every death certificate in the country is electronically collected, and we access the national mortality data, which has everything that's on the death certificates. We access the national database of all hospital admissions, including outpatients admissions, which I could use for the vision data. So there are these repositories. You need permissions to access them. But now I'm actually based in the Department of Health. I mean, previously I was in Public Health England or other agencies. But with the right permissions, you can access these really big databases, and you can link them as well.
I was wondering if you've drilled down particularly in the severe mental illness co-diagnosis with cancer. My impression as an oncologist is I very rarely come across patients with SMI, I mean anxiety about their diagnosis and so on. But in living memory, I can only think of one patient actually committed suicide, for example. And I presume on the death certificate it would have been their cancer diagnosis and then suicide, or whichever way that would be. But it's not something that I really see a lot of, and I was just wondering whether you've looked at that in your data sets. I mean, part of the problem, because some countries are Canada. Some others are bringing euthanasia. I think next year they're going to bring it in for SMI as well. I mean, an option to from April that you can just have euthanasia for mental illness.
Yeah, that is truly terrible, because you know, what's been described is the slippery slope. If you introduce physician-assisted suicide, I mean, there is good evidence. The people who promote it say no problem, no problem. But actually, if you really look at the data from Holland, from Belgium, and probably emerging now from Canada, there is a slippery slope. So if you have physician-assisted suicide, or in Switzerland, it's different. You go to Dignitas Clinic. There is a slippery slope, and so people with conditions that they're afraid that they're going to be a burden on their loved ones, on society, that they're not going to manage, they start asking for it. But back to the thing about I think the reason you haven't seen many people, so I think if you're working in a hepatology clinic, you probably would have seen some people with severe mental illness and particularly alcohol-related liver disease, is that it still is a small, I'm making a huge deal of it because it is a tragedy and an injustice. I suppose compared to the totality of the population, SMI is still relatively rare, only affecting a small percentage of the population, 2%, somewhere between 2 and 4%. And so maybe that's why you don't see many people that you know have schizophrenia and cancer.
My problem is patients are very optimistic, sometimes more than I am.
Yes.
Yeah.
Yes.
Treatment, very rarely negativity. That's like, what can you offer next?
Yeah. So yes, well, that really is a challenge.
Stress on my part, because sometimes there is nothing except for hospitals.
Yeah.
You know, there are issues of what's actually realistic.
Yeah. And we do see, although I've got absolute huge respect for hospices, sometimes they don't take people with these sort of problems and alcohol-related problems. But yeah, it's a challenge. It's really a challenge.
Is there anybody who is participating in our Zoom session who would like to ask a question?
We talked a lot about cardiovascular cancer, but what about obesity? I think that's another, I mean, not only childhood, but obesity. Are there any similar atlas for obesity? I'm sure deprivation and, I mean, liver disease, now chronic liver disease, the most common cause is fatty liver disease, not alcohol anymore. So I think it's something to look out.
Yeah, so absolutely. I'm not sure if it's topped it yet in England, but in the States, 100% obesity is commoner. And actually, if you're obese and you drink heavily, bye-bye liver. It's very, very bad news for your liver. So I don't, it's not in my group, the group that's working on cardiovascular risk factors. They haven't produced an atlas, but they have similar indicators. So on the Fingertips platform, there are lots and lots of indicators about obesity, about smoking, about cardiovascular disease. And cardiovascular prevention and action on obesity and smoking is a big thrust of the government's major condition strategy. The problem is that we actually haven't had any success. I mean, I enjoyed your lecture, your questions at the last session that was in April. It was such a good CPD session for me. I've been quickly filling it in on my CPD form because I learned so much about endocrinology, about obesity, about heart failure, all things which, as you can see, they're not in my field. So I absolutely loved the session.
Philips, I didn't manage to put my head about the medications and how the price drives anything. So now in diabetes and obesity, we have a fascinating situation because a new medication for obesity came out and there is a shortage. So the companies are unable to provide enough. So that leads to the further shortage of insulin, which goes into the same pens, because obviously company prefers to put GLP-1 into the same pens, and they don't have enough companies making plastic to make these reusable pens. It's absolutely fascinating for me to watch it, how actually demand is much higher than the companies are unable to produce, and what it leads that they are not putting insulin, which is required for life, to choose to put the GLP-1 into the pens.
That's
Yes, but it's just fascinating to watch about the economics of medicines and how it's all introduced and what people are what people want to invest in, and yeah.
It's absolutely shocking. And not long ago, there's also a shortage of EpiPens.
I mean, do you know, I'm a GP. I've been a GP for over 20 years. I mean, the drug shortages have never been that bad. Even simple drugs, metformin stuff, not available. I'm doing HRT. I'm a specialist in HRT. We have to juggle and change all the time because there is, a shortage of this preparation. It's absolutely unbelievable, and that's never ever been like this.
Yeah.
No, I don't think it's only Brexit.
Who of you? This is being broadcast over the country. Who was on the march yesterday? I was looking for you all. The pro-European anti-Brexit march. I was there. I've got the pictures. Yes.
You're working, not striking. Any more questions?
So the databases that we use, they almost be live. It's 1 month delay, and we start creating the dashboard that will feed the same data. Almost like
It would. Yeah, it's a really good question because the atlases take a long time to prepare, and that's why I'm splitting the lung cancer atlas into sort of background. But even so, the data from the National Cancer Registry, NCRAS, is 2-3 years out of date. That's like when I was a director of a cancer registry years ago. And we need much more current data. So for some data, like mortality data and the HES data, you can use it much. So the interesting thing is, during COVID, we got access to the fast production of data, and we could measure very quickly within days and at least a month changing patterns of outpatient usage or deaths or anything. And in fact, we couldn't monitor deaths fast enough with ONS registration, although the GPs were then allowed to register online and change lots of things changed. But we contacted CQC because when somebody dies in a care home, the care home has to notify CQC, so we could have the notification within a day. But you're right, we're not doing it fast enough. And I hope there'll be important developments. We're going back to our colleague's question about where does the data come from. It must become more real time, and we must link it better, and we must have better access as well.
It's very interesting, but do we know about it, to be honest? And coming to clinician, I don't know where to look for it. And knowing the data and what it shows, I could try to influence my manager or the director of the hospital in a way.
So there will be somebody in your hospital who is analysing, they'll call it PAS, is the patient administration system. So they will be able to, and there should be a little team who are actually analysing data in your hospital, and they should be able to help you with that.
Any more questions? Thank you very much, Julia. It was a fascinating talk. It was really, really very interesting.
I had a question.
Oh, there's a question. There's Ewa?
Yeah. Wiesz, słuchaj, naprawdę nie słychać, wiesz.
Okej, ale teraz cię słychać, Ewa, tak? To jest Ewa?
Tak.
Tak, to jeszcze jest Ewa. Ewa, jedno pytanie od Ewy.
Ewa,
teraz powiedz.
So briefly, a question really about epidemiological data for pediatrics, and what we've noticed is the very high frequency of usage of ethnic minorities, deprived individuals using hospital services as opposed to access to primary care and health visitors, and mapping all of that. we're finding it quite difficult to get that translated into funding and access into these populations to try and prevent disease in small children. How are you involved in that, or what sort of policies are now being implemented to try and get better access for young children, families deprived, because that has an outcome and an effect on their whole lifespan?
Thank you for that very important question. Monitoring and using the data on children is, apart from in mental health, isn't in my remit, but there is another team that works on maternal and child health, and they publish indicators also on our Fingertips platform. If you write to me, then I can give you the link, or otherwise Google child and maternal health and Fingertips, and you should get to the platform and be able to negotiate it. But you're absolutely right. I mean, it's the same pattern that we described in palliative care, that people from ethnic groups are more likely to turn up at A&E. For children, the same. And of course, in the sort of a decade ago, we had lots of programs like Sure Start, and there are other programs investing in more deprived areas to try and give children a better start in life. But it is absolutely critical to even up the experience of mothers and children to try and reduce some of these problems that we're seeing in later life. Because if you come from the most deprived backgrounds, and perhaps you're also from an ethnic minority group, your chances of having good health later in life are dramatically reduced, and in part because of education, of housing conditions, of fuel poverty, but also in terms of understanding how to access health services.
Thank you. I mean, that is a real problem, because Sure Start has finished. A lot of the obesity programs for teenagers and adolescents have also finished because of lack of funding. And we're seeing this as an increasing problem on the public health spectrum, really.
Yeah, no, I absolutely agree with you. And the predictions for the future are terrible. They'll end up in Philip's clinic with heart failure, very, very young.
Absolutely. Absolutely. And liver failure.
And liver failure, yeah. Well, perhaps I'll set up a clinic side by side with Filip, and we'll deal with the two together. Thank you.
Okay, thank you.
Thank you very much. Thank you. Thank you. Bardzo dziękuję. That's not the end. We have another thing to like. Thank you very much, Julia. Oh, that's pleasure.
I would like to take this opportunity to congratulate one of our colleagues, Agnieszka Michael. She was recently awarded a title of Professor of Oncology. I would like to ask Piotr Szosarek, who is also an oncologist, who's known Agnieszka for a very long time, to give us a little bit of sort of overview of Agnieszka's career.
Well, thank you very much. It's a great pleasure to say a few words about Agnieszka, who, you're right, I've known probably about just under 25 years. So I first met Agnieszka at St. George's Hospital. She joined the rotation where I was a trainee as well. I think you finished medicine in Wrocław in 93. And then following your registration in 98, you then joined us as a trainee. So, you know, we worked there, and I was actually, you know, it was great to see a colleague from, had a background from Poland, who was also very optimistic and a realist and pragmatic in her approach to patients, which I noticed back then during training. We then parted our ways. Agnieszka stayed on to do a PhD at St. George's in cancer vaccines. I think that was ordered in 2006 under your supervisor, Hardif Panda. And then you broke into urology and gynecology, where you've sort of stayed since at Surrey, at St. Luke's in Guildford, and you also run the clinical trials unit very successfully there, with all the pressures that we know in running that sort of unit. And most recently, Agnieszka has been honored also with a oral presentation at ASCO, which is the premier society for oncology in Chicago. You presented on your own area of interest, particularly, which is on frailty. I think there's actually a lot of complementarity with the talks we heard today, thinking about it, on your a tool electronic frailty index, which I think is very interesting. And you've shown that you know, you can use this tool to decide whether patients may benefit or not from chemotherapy using the big database from Public Health England on 30-day mortality. I think a lot of oncologists can learn from this. This area, yeah, I think this is will be a much bigger area going forward, and certainly it could even be used to decide on whether some trials, which we discussed earlier, should be taking place or not, because you could use this tool actually probably to predict the outcome of your phase 3 trial before wasting all that money and patient health as well. So just give a round of applause for a great achievement for Agnieszka.
Thank you very much. I really didn't expect such a warm introduction, and thank you. This is really a great pleasure to be able to share this good news with you. As Peter said, I'm an oncologist, and I've been working with cancer for more than 20 years. I mean, you don't need to give all the dates because it just shows us how old I am, but it is my passion. I mean, cancer and initially immunology of cancer has been the most sort of fascinating field of cancer, because we always knew that this is going to be what's going to revolutionize cancer treatment. You know, that was always, before it all started developing, that if we are going to beat cancer, it's going to be using our immune system. But it's taken many, many years. A lot of research I was doing over the years was involving cancer vaccines, gene therapy. And although that has made a huge progress, it hasn't really done this big change, which is what we see now with the immuno-oncology and sort of amplifying the immune system response that we're using. Yes, I mean, we've had 2 fantastic lectures today, so I'm not going to elaborate anymore. I'll be really delighted to share it with you one day. And just wanted to say thank you very much. This was really a great honor. Thank you. Oh, yeah, another photograph.
Thank you. Thank you very much. So I have just a couple of final points, and then we are finished with our formal part of the meeting. Just wanted very briefly to mention what we are planning for our next year, to be honest. So next month in October, 29th of, przepraszam, po polsku będę już mówić, 29 października, czyli za miesiąc w zasadzie, planujemy spotkanie w Instytucie Sikorskiego. Proszę pamiętać, że to będzie w Instytucie Sikorskiego, a nie w Ognisku, ponieważ Instytut bardzo uprzejmie zgodził się wynająć na naszą salę. W zasadzie nasza baza i nasz adres jest w Instytucie Sikorskiego. Jesteśmy od wielu lat związani z Instytutem, ale przez pewien okres czasu nie mogliśmy używać ich sali. Ale wyjątkowo dostaliśmy pozwolenie, więc następne spotkanie 29 października będzie właśnie w Instytucie Sikorskiego i będziemy gościć panią profesor Dame Jane Dacre, która jest prezydentem of Medical Protection Society, i ona będzie da nam wykład na temat medical negligence. Także to będzie ciekawy wykład, ale również będzie okazja dla tych osób, szczególnie młodszych, żeby zobaczyć Instytut i muzeum, bo tam jest naprawdę bardzo dużo ciekawych eksponatów. Nie wiem, czy wiele osób już miało okazję tam być, ale przy okazji wykładu można będzie sobie po prostu zwiedzić również muzeum. Zapraszam wszystkich serdecznie na nasz Christmas Dinner, który odbędzie się tutaj w Ognisku na dole w restauracji 9 grudnia w sobotę. Także proszę sobie zaplanować, jak to się mówi, save the date. W przyszłym roku planujemy też kilka ważnych spotkań, ale jeszcze daty i wykładowcy są do potwierdzenia. I jedną rzecz, którą na pewno możemy potwierdzić, to jest bal 1 czerwca, ponieważ salę już mamy zarezerwowaną, więc ten bal na pewno odbędzie się w tego dnia. Wspomnę jeszcze na koniec, że nawiązaliśmy ostatnio kontakt z Federacją Polskich Organizacji Medycznych, która ma siedzibę w Chicago. Federacja istnieje już od prawie 30 lat. Nie wiem, niektórzy starsi członkowie może pamiętają. Ona została założona przez naszego byłego prezesa, pana doktora Kazimierza Nowaka. Federacja dość prężnie działa. Teraz mają nowego prezydenta, pani doktor Kornelia Król, która się ze mną skontaktowała i zaprosiła do współpracy. Federacja organizuje też bardzo dużo ciekawych spotkań, skupia w ogóle 18 medycznych organizacji na całym świecie, także dość prężnie działają, organizują konferencje, spotkania, bale i tak dalej. Więc jeżeli będą jakieś ciekawe wydarzenia, będziemy Państwa informować poprzez nasz biuletyn. A osobiście jako zarząd właściwie mamy bardzo dużą energię i ochotę się, że tak powiem, od nowa zaprzyjaźnić z federacją, bo nie było kontaktu przez dłuższy czas ze względu do tego, że nasza organizacja troszeczkę może mniej działała, a federacja też no może nie była tak aktywnie zaangażowana w kontakt z nami. Także to wszystko. Zapraszam wszystkich bardzo serdecznie na obiad w ognisku na dole. Jest przygotowany stół, tak?
Thank you. That group, international group, they used to have Doctors Olympics and all sorts of things. I mean, I never got to participate, but they used to, hold it in Czestochowa or somewhere, and they had like swimming and Pani Bożena, pamiętam, and different sports, fencing and so on. But I also would like to ask, so my great uncle was a member of the society, and I'm sure you've got a copy of that one.
This copy is going to become electronic quite soon and will be on our website. This book is written by our previous president Nowak, and it's the described history of the Polish Doctors Association dates back to 1954.
And so
that was written on the 50th anniversary of our Association.
And my question is, because next year will be not only the 80th anniversary of Powstanie, but also of this, are you going to update this one?
We will absolutely. We are planning. I mean, the plans are not yet crystallized, but we are planning to celebrate our 80th anniversary. So we'll keep you informed. That's probably going to be sometime. Yes. Definitely, remembering the 50th anniversary, it was a 2-day event with a ball in Parliament, so it was a big thing. Well, I'm not sure whether we are going to match it, but we're definitely planning celebration. Thank you very much, everybody. We invite you very warmly to join us for lunch downstairs, please.
Dobra, dziękujemy bardzo wszystkim też na Zoomie. I dziękujemy za obecność bardzo. I za aktywność też, szczególnie Ewie. Pozdrawiam wszystkich.
Dzięki, cześć. Pa.
Majcie się, cześć. Teraz was słychać nawet, jakby tak chciał coś powiedzieć, a jeżeli nie, no to jeszcze chwilę będę może trzymał to włączone, póki się będziemy pakować.
Dzięki Tomek, cześć, pa.
Ja też pozdrawiam wszystkich, ja dopiero z lotniska,
Super.
także niestety nie mogłem...
No jasne, bardzo fajnie, że byliście i tak, to było bardzo fajne. Trzymajcie się ciepło.
Pa.
Do usłyszenia, do zobaczenia.
Na razie, pa.